मिले जानकारी, जच्चा और बच्चा स्वस्थ रहे ये समझे जिम्मेदारी।
India today is being considered a world leader on many fronts. However, even with all the impressive growth statistics in recent decades, major health issues specifically pertaining to maternal, newborn, child health and nutrition continue to be areas of major concern. The hurdles to all-round health have been many and varied. The key factors stalling progress, however, may be narrowed down to the status of a woman in terms of her geographical location, her socio-economic standing, and her culture. In addition to these factors, like poor healthcare systems, ignorance of relevant schemes and services, and their accessibility, make the situation even more complex. All these also ultimately impact on safe deliveries for pregnant women, resulting in the high number of maternal and infant mortality. Concerted national efforts have been directed towards improvement in maternal and child health through equitable, affordable, and quality health care. In fact, this focus is central to the achievement of national health goals under the National Health Mission as well as the Millennium Development Goals 4 and 5 as formulated by the United Nations. To complement these goals, while firmly believing that each woman counts and that despite her class or caste has the right to have a safe childbirth, MAMTA Health Institute for Mother and Child started its first operations in 1990 at Tigri, a slum at southwest Delhi, which had one of the worst indicators in terms of MMR and IMR for an urban slum.
The aim was to bring as many women into the gamut of healthcare as possible and then to connect it to the child health along with as a continuous process. As MAMTA moved on from the urban poor interventions to the rural poor interventions, it also moved from purely focusing on maternal and child health to a life course approach, which means that children, adolescent and maternal health became as a continuum of care rather than just focusing on either child or maternal health. Along with the journey, it did look at the epidemiological evidences as it moved on and came in the issues of HIV and tuberculosis as two areas of integration that we did in the care of maternal and child health. The prime focus of MAMTA has been on community processes, community institutions, health system strengthening, and doing policy initiatives. In the process, MAMTA has strengthened the national policies, or has worked in national policies, and as part of the UN advisory groups and part of the technical groups at the international platform, has been able to position this agenda at the global level also.
We have worked with a huge number of development partners, with the Government of India, with the national agencies, international agencies like SIDA, UNICEF, with the big foundations like MacArthur Foundation, and with the corporates also.
There are many like-minded corporates who have shown interest in our work and who are partnering with us on various issues of maternal, newborn child health, adolescent sexual reproductive health. So we are doing a lot of implementation because they do agree with the type of work MAMTA is doing, with the type of strategies we are following, because we do focus on women issues, we do focus on gender and empowerment. That is cross-cutting throughout all our thematic areas.
With all the support, we have worked in 18 states of the country in the past, in Nepal, in Bangladesh, and also through our capacity building initiatives in 10 more Asian countries.
We know health is a key determinant to poverty, right? And hence we would say we have worked on MDG 1, MDG 3, MDG 4, MDG 5 and MDG 6, both at national and regional level. By bringing in a community processes which are more entrenched in an inclusive approach, results in increased access not just of the populations who are closer to facilities or who are from a upper caste families. It increases access from the families where the real burden of maternal mortality and morbidity lies. And that's where I think India or any low resource setting is going to see a great advantage in improving their maternal mortality outcomes, or MDG 5 as we say.
The experience of working with various communities provided MAMTA with an understanding that a life cycle approach considering health of adolescents and young people along with women and children is significant in terms of overall health and development status of any community. This was an understanding that could very well be applied to counter the issues and hurdles stalling provision of sound mother and child health. It was against this backdrop and the fact that many national and international agencies have been pooling their resources together for the cause that MAMTA proposed for a project to be undertaken with DFID UK, and for this it focused on 2 least economically developed, remote and hostile districts of Uttar Pradesh with exceptionally high MMR and IMR.
Here the status of the women is very poor. Major issues are gender, they don't have a proper livelihood. Even the decision making powers and negotiation skills of the women are very poor. All these are controlled by a male dominant society as all over in India, but this area is also very affected because of the anti-social elements over here and the difficult terrain of this area.
This project was initiated with the intention of reaching out and mainstreaming such women that were unconnected or were associated in a different manner with the society like the SC, ST or the Muslims. The endeavor was to ensure that they were able to accrue the benefits of the government schemes relating to health and other social aspects.
They would not let us speak to anyone. Mother-in-laws, they said that we would incite their daughter-in-law, and as a result they would run away to their parents. They believed in the myth that when the boys take the polio drops, the future generation would become infertile. The second myth was related to family planning. They believed that children were God's gift and one should not stop delivering children. The third myth was related to stopping the teenage girls or even pregnant women from consuming iron capsules, even if they were anemic, and they believed that it resulted in loose motions or was poisonous.
पहले हमको ये भी नहीं पता था कि ऑपरेशन सरकारी अस्पताल में ऑपरेशन भी हो रहा है.
Previously, I was not aware that operations can be carried out in government hospitals. We spent a lot of money and repaying the loans took a lot of our time and energy at the cost of our family.
समय बर्बाद होता था जिससे हमारे परिवार अच्छा से चल नहीं पाती थी.
Women practiced the parda system much more in the Muslim areas and they just would not get involved.
The key objective was to create awareness for issues relating to mother and child health and nutrition, and also for empowering women specifically belonging to the BPL sections and SC, ST and minorities to generate livelihoods for themselves and their families. The overall goal was to reduce MMR and IMR in these areas. The prime challenge lay in bringing about a positive change within the community through social inclusiveness. And this had to be done by overcoming the prevalent myths and misconceptions and also by changing the mindset. This in turn implied careful and focused planning, implementation and monitoring of the government schemes, and interacting with and motivating women to express themselves at all platforms, besides addressing issues on gender equity. The challenges were thus many and had to be addressed holistically with out-of-box solutions. However, initially the foremost priority demanded recruiting a task force that could work in the field and proactively implement the strategies chalked out.
In the selection of the staff also we take the inclusive approach, because then in the implementation also they will be able to understand the pain, the dilemma of the community, and therefore they will be able to suggest and guide the community.
ग्राम प्रधान ही हर गांव का मुखिया होता है. Our first strategy was on how to reach out to the community and make an entry. For that, we tapped the Gram Panchayats, who were considered to be gatekeepers. The Gram Pradhan is chief of any village. We chalked out a plan with his support. with the panchayats and all its members through an orientation program on what we intend to do with women in the community, especially those women who were left out of the mainstream. The second strategy was to involve the community members themselves. The third strategy was to appoint group leaders from within the community itself. Even the volunteers were chosen from within the community. Persons who understood the community and who could also communicate with them effectively. This was our primary strategy at the implementation level. Another strategy was to promote the implementation at the district level. Yet another strategy was to conduct consultative meetings at the district level to have an interface on each issue between our staff and the beneficiaries. Here the beneficiary suggested himself the kind of services that he required or expected.
वो लोग भी रहते हैं, वो बताएंगे क्या-क्या सर्विसेज कहाँ से मिलती है, कैसे सर्विसेज मिलती है.
We had a discussion about the joint association of the panchayat in terms of livelihood and in terms of health issues of the community.
To bring about greater levels of community perspective, accountability and transparency on the project deliveries, MAMTA has put in place a beneficiary feedback mechanism in the 4 villages of the target area with the support of World Vision UK. The learnings from this feedback mechanism have created an opportunity to revisit project strategies from time to time.
इनके समूह ने जो है प्रेरित किया, गांव में इन्होंने प्रोग्राम किया. पहले जो महिलाएं नहीं आती थी वो महिलाएं.
अब आपको इसकी व्यवस्था नहीं करना है ट्रैक्टर की व्यवस्था करो, गाड़ी की व्यवस्था करो.
The group inspired the villages by organizing programs. Those women who would stay back earlier have now developed courage to speak for themselves. They have also been creating awareness in an entertaining manner about need for delivery in hospitals and need for savings for difficult times. Now almost 50% of women have an account in post offices.
MAMTA's work is different and more effective because they contact door to door, while we are sitting here and cannot do that. Asha has been allocated a target area which they are not able to cover. MAMTA, on the other hand, is able to create an awareness among the people due to their door-to-door outreach.
Had various trainings of the staff quarterly for on various issues like communication, how to reach the community, how to give the trainings, how to negotiate with the local people, how to engage with the panchayats, because there are various practices on which the maternal and child health is dependent on. Unless we have a whole sphere of people contributing toward the maternal and child health, the objectives of the project cannot be achieved.
In the thematic camps, we undertake activities like mother-in-law, daughter-in-law sessions. In one of the meetings, it came across from a woman that her husband does not let her come out of the house and requested us for organizing a thematic camp where all the husbands and mother-in-laws are invited on the same platform, creating awareness so that a solution can be found out to their problems. Firstly, we changed ourselves. When we changed ourselves, then gradually we changed the community. Previously, water was not offered to lower castes in presence of the higher caste. But since MAMTA came here, such discrimination does not exist anymore.
Information was given by them to the BPL families on how to get pension or how to get an Aadhaar card made. The males were not at all aware of this information earlier. They go out of their homes in the morning and return by evening and are not able to attend to their homes, nor look after or guide their children. When we started involving the males, they started grasping the issues and gradually they started motivating the females of their house.
The task cut out for MAMTA's field-level staff was clear. They had to focus on strengthening the delivery and improving awareness of health services. They had to empower women to adopt safe motherhood and childcare practices, primarily through capacity building and behavior change communication. Capacity building was envisaged to bring about change at 3 levels: at the individual level, at the institutional level, and at the community level. A three-tier system of operations was planned as a strategy. The ORWs and peer educators worked at the grassroots, interacting directly door-to-door with the beneficiaries within the community and with the service providers like PRI members. ANMs and ASHA workers were trained and motivated, and coordination was maintained at the systems level. The strengthening at the institutional level was done by activation and improving the functionality of the various committees like VHSNC, Rogi Kalyan Samiti, Matra Samiti, Gram Sabha and Manrega Social Audit Samiti. And lastly but not the least, at the community level, the BDOs and the village pradhans were convinced to support the cause. All this was made possible by ensuring effective participation of community institutions like the Panchayat, Gram Sabha, Village Health and Sanitation Committee and Matra Evam Kishori Samiti in the ICDS department through a series of interactions and meetings with them. This initial first-hand knowledge gained by MAMTA's field functionaries helped the project planners and executors in setting priorities and chalking out methodologies at the macro level and in fine-tuning the day-to-day activities at the micro level. Community mobilization and strengthening of women's groups, community institutions and health system were the key proposed approaches through a series of innovative activities. Activities with specific target groups were aimed at empowering the individuals and groups on MCH issues. Awareness and mobilization was achieved through thematic group sessions in the community involving women, men, and mother-in-laws. The impact of the sustained efforts was gradual but infectious and lasting. The key to effectiveness of MAMTA's approach lay in persistence and in addressing the people in groups. This approach ensured that the stakeholders could interact with each other and share and learn from their individual experiences. The collective sharing also resulted in clarifications of doubts and a better understanding of the issue involved. The result was also in tandem with MAMTA's innate policy and belief that working towards maternal and child health is a sound investment strategy, and that it is important to speak collectively, act quickly, and thereby bring about a long-lasting change.
As compared to earlier, MAMTA has been organizing camps and informing people about common schemes. This has created awareness among them. Now there is no difference between a boy or a girl. Now people are aware that 1 or 2 children are enough. Earlier it was a question of earning and doing everything myself, while now the feeling is that yes, we should both complement each other.
Now 18 out of 20 registered women come forward in contrast to only 5 out of 20 earlier. Moreover, they come themselves rather than their children or husbands.
और वो खुद निकलने लगी हैं और आने लगी हैं। समझाना हम लोगों का भी कार्य है कि आंगनवाड़ी होके कि हम लोग
As an Anganwadi worker, we also tried convincing, but people could not understand much. But MAMTA's approach of discussing in groups made the difference.
उनको बताया जो है तो वो लोग ज़्यादा समझ रही हैं।
The first girl, the mother-in-law, was unhappy, but when the second child was also a girl, she celebrated. There is a sea change in attitudes relating to gender. Earlier there were no drainage system, but now there are proper drains. Roads have also been constructed after MAMTA started its work here. Solar energy was also introduced. However, the most important thing that has happened is of understanding how to run one's house and family efficiently.
As 78 lavatories are being built, out of which 55 are complete. This contributes to the safety of our women, as now they do not have to go out in the open for defecation. Till recently, the ANM would never go to the village and work, but after MAMTA came here, the ANM have also started going door to door.
Much change has taken place here. Females would not go for vaccination for sake of their health or their children's health. The pregnant women would also not go. Ever since Mamta came here, they have started getting vaccination.
ज़्यादातर अब गरीब तबके के लोगों को पहले नहीं गौर करते थे, आ जाते थे उनको पोषाहार
Earlier, the poor women were ignored if they did not come for health checkup. But now we go out of the way to ensure their nutrition so that they and their children remain healthy.
तो उनका ज़्यादातर अब ध्यान देने लगे।
पहले ये था कि कोई मतलब सरकारी योजना नहीं थी, ना कोई बताने वाला था।
Previously, we were unaware of government schemes, nor there was anyone to guide us. Now, MAMTA Society, ANM, ASHA, all are there to guide us during childbirth.
मिलता रहता है सुझाव, तो अब उसी हिसाब से बच्चा पैदा होते हैं।
मनरेगा के तहत लोगों को मजदूरी
Providing work to people through Manrega has benefited the economically deprived. They have got some relief through this. This awareness has been imparted by MAMTA.
लोगों में ज्ञान जागृत हुआ है।
दाई थी हमारे गांव में 2-4 वही पुरानी दाई, वही करवाती थी डिलीवरी।
There used to be 3 or 4 midwives who would take care of deliveries in our village. Going to hospitals were discouraged, especially by the mother-in-laws. But now, except for emergencies, all deliveries take place in hospitals.
अस्पताल में होता है इसके आने से।
उनको बताते हैं।
They are told to go for this scheme so that they would have some money to spare. They would feel empowered and would be able to take care of their own and their children's health.
मुसलमान लोग जो थे तो
Muslims would not even give polio to their children, but now they go for vaccinations and even operations. Now they have 1, 2 or at the most 3 children. They have all become very informed.
हम लोगों से टीके भी लगवा लेते हैं।
पहले तो ऐसा होता था।
Earlier they would make us work and still not pay us our salary, saying that salary has not reached them or has been deducted. Now we have acquired information on this through MAMTA and can fight for our rights.
हमारा अधिकार भी है।
The people initially refused once or twice, saying that you had the time to do this, that is why you are involved in this. Then I argue that take out time for this only because such improvement is needed in our lives. Then they also devote time and are now offering their full support.
The success of a project can be ascertained through its ownership by the beneficiaries and all stakeholders. MAMTA ensured that the villages imbibe the need for the project and adapt its salient features in their daily lives such that the momentum towards development does not lose steam.
देखिए ममता ने आज के
MAMTA has now empowered all our ANMs, ASHA and Anganwadi workers, along with other members to such an extent that they are self-sufficient. With this firm foundation, we will face no difficulty in implementation. Then all we will need to do is to evaluate.
उसका मूल्यांकन भर करना पड़ेगा।
ममता का जो प्रोग्राम है वो नॉलेज लेवल को डिलीवर करना कि समुदाय।
MAMTA's program aims to deliver at the knowledge level while empowering women with the information. For this, we have linked up the SHGs with the Rajiv Gandhi Ajivika Mission, such that they can get loans for setting up small-scale industries. So this is another aspect of sustainability. Even when we are not around, they can still get associated with government schemes and sustain the program. Our main aim is that the women get opportunities for generating income, such that it ultimately results in improvement in MMR and IMR.
का अवसर मिले जिससे वो मातृ और शिशु स्वास्थ्य में सुधार ला सके।
बाद में खुद भी औरतें भी जागरूक हो जाएंगी।
While we have the knowledge now, later all these women would also be aware themselves, and then much convincing will not be required. When the aware women who are between 15 to 45 years now will bear children, their children will also be informed about health and also saving. We will also do all that work that MAMTA is doing now while involving Matra Samiti or Kishori meetings.
या किशोरियों की मीटिंग के द्वारा उन तक पहुंचाएंगे।
Creating a model project for replication elsewhere has become a habit for MAMTA as an organization. After working for 2.5 decades in the field of MCH and N, MAMTA's key activities now encompass within their scope a much wider range. Apart from advocating for maternal and child health, MAMTA now provides technical support to the government for strengthening MCH and N policies and initiatives. At the same time, it also focuses on strengthening of monitoring mechanisms and supporting pre-project surveys and post-project evaluations that focus on the demographic impact of interventions and the impact on the quality of healthcare.
And I think as MDG 4, 5, 6 are going to be integrated into one goal, as I understand from health perspectives, then it will be great to see how the health journey gets integrated within the journey of gender, and how the new agenda that we have began with, that's the non-communicable diseases, in last about 3 to 4 years, is going to be mainstreamed within the Sustainable Development Goals. Although NCD had no separate goal in the MDGs, but it's going to be one of the important drivers in the Sustainable Development Goals and women are going to be the real one of the elements that we need to address when we come to NCDs, young people and women, both, I must emphasize.
With this, MAMTA is now poised to capitalize on its 25 glorious years and move much beyond.
हम घर से रजिस्टर लेके चले ममता में जाके पहुंच गए, ममता संस्था में पहुंच गए, ममता संस्था में पहुंच गए। हम घर से रजिस्टर लेके चले ममता संस्था में पहुंच गए। ममता संस्था में क्या देखा, क्या देखा भाई, ममता संस्था में क्या देखा, क्या देखा भाई, सरकारी योजना दिलाने में हम तत्पर आगे खड़े हुए, सरकारी योजना दिलाने में हम तत्पर आगे खड़े हुए, हम तत्पर आगे खड़े हुए, हम तत्पर आगे खड़े हुए, सरकारी योजना दिलाने में हम तत्पर आगे